This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I interviewed Dr. Darren Earnshaw to discuss how he integrates different musculoskeletal models into his practice. Dr. Earnshaw is a PT with over 30 years of experience, Masters of Manipulative Therapy, a Fellow of the American Academy of Orthopedic Manual Physical Therapists, a Certified Orthopedic Manual Therapist, Certified Mechanical Diagnosis and Therapy, and MAP Senior Faculty Advisor. Darren has also completed a Clinical Movement Science Fellowship through Washington University. In our discussion, we will explore how he integrates his manual therapy, MDT, movement science, and psychosocial knowledge into his assessment and treatment. If you find this information valuable, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share with other clinicians who might benefit from this information. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything Anytime EMR. Systems for PT develops systems for clinicians so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Sarah Health. Have you heard of remote therapeutic monitoring? Does it sound complicated and hard to implement at your practice? It doesn't have to be. Sarah Health is revolutionizing RTM, making it straightforward for your practice. From easy onboarding to hassle-free billing, they cover it all. Hi Darren, welcome to PT Pro Talk. How are you today?
I'm good, thanks very much.
Awesome, let's start talking a little bit about yourself, your career, and your background for the ones that don't know you yet.
Okay, so I'm an Australian trained physiotherapist, graduated back in 1992 in Perth, graduated with a Bachelor of Science, graduated feeling pretty clueless. My first couple of years out, which I think most of us are like that, I felt almost embarrassed to be in a room with a patient and thinking, I'm the guy that's going to fix you. So in Australia at that point, if you wanted to specialise a little bit more, you could go back and do a postgrad diploma in sports or a postgrad diploma in manipulative therapy. And I, in 1996, so I think I've been out 3 years, went back and did the manipulative therapy one. And originally I was going to do sports because I sort of liked sports, but everyone was telling me do the manipulative therapy one because Bob Elvey was running it. And I'm assuming, have you heard of Bob Elvey?
No.
No, Bob Elvey, you know, all the upper limb tension test stuff that we all do. He really laid the groundwork for that. He did a lot of cadaver studies, etc. That's what he's renowned for, but actually he just was an amazing sort of physiotherapist and human being. So they had him in, he was running the program. Max Zussman was in there, who was a big pain guy, sort of pre-Butler. And then even Peter O'Sullivan actually was doing his PhD at the time. So he stuck his head in every now and then, which was quite interesting too. So I went back in 96, did that. Then I came over to the States. And since I then did the McKenzie certification, I think about 2000, done a lot of other continuing ed. And then sort of went back in 2017 and did a fellowship under Shirley Sarman's crew down in Washington University because I felt I just didn't know what they were doing, which is a whole story in itself. And then also had been exposed to a lot of Peter O'Sullivan's stuff. So I sort of hybridized it all in together. Did my transitional doctorate a couple of years ago, I think, with evidence in motion as well. So I'm basically a clinician. I spend most of my time in the clinic. I have mentored in fellowship programs at the University of Illinois. They had a manual therapy fellowship. I was involved with that for 10 years. So that had me in academia just the right amount because I am definitely not an academic.
Well, so I think it's interesting that you were exposed to so many different approaches and methods. So I was curious to ask you, how do you integrate them? Because they can be different. So like, how do you go about using all those different approaches that you have learned through all
lucky
these
for
years?
me, I think when I originally did my fellowship in 1996, which was sort of the life-changing event for me, it taught me to think completely differently to how I was thinking going into it. So I went into it thinking, you're going to teach me how to work out if it's a facet joint or a disc or a muscle, and then treatment's easy because I have the answer. And when I popped out the other end, I realised that life's not black and white, it's all grey. And by recognising that, I understood that you actually have a lot more power in your ability to treat people. And that's the reality, isn't it? We don't know a lot of the time exactly what's going on. And you don't even really have to know specifically the tissue you're treating to still be able to get a good result. So I had this thinking process that I was taught. And it's a bit Maitland-esque in as much that in Australia, I didn't even realise I was getting a lot of Maitland. So I was from the West Coast. Maitland was from more the East Coast, I think Adelaide. So we were never told you're getting Maitland per se, but we were really getting the Maitland subjective, and the Maitland physical assessment was definitely what we were taught a lot of. But especially in the fellowship course, we were taught about reflective thinking and questioning your beliefs and questioning everything. So moving forward through my career, whenever I'm exposed to new stuff, the way I look at it is a little bit different than just believing everything that I'm told. So I try to just integrate it all together. I've always been looking for this perfect model of whoever walks in my clinic, I want to be able to treat them as best I can. And if you get stuck in one model, there's a large proportion of patients that you're just not going to be able to treat. So primarily I was a manual therapist. So when I would see patients, I would always get my hands on them and do joint mobilizations and manipulations. And I learned pretty quickly that I wasn't getting everybody better. But I didn't know why. And then as I get exposed to different things, suddenly there's a little cohort of patients I wasn't getting better before that now I can get better because I've seen another approach. So when I did the McKenzie stuff, I found that really useful for a bunch of spine patients that weren't getting better with just the Maitland approach. So I've always tried to sort of put it all together, though, in a non-guru way. I don't really like following gurus. Gurus have a lot of rules, and I sort of think I don't really like following rules. And I think that if you get locked into rules, again, you lose your lateral thinking. So what happened to me was I thought I had been trained at one of the best fellowships in the world, which at the time it was sort of considered one of the better ones. So I had a bit of a chip on my shoulder. I thought I was pretty good. And then I've been out about 10 years and I thought, I've got a fair bit of experience and I've been trained really well. So when I would get exposed to sometimes different approaches, I would, instead of really relaxing and opening my mind and thinking this could be something completely new, I would always be trying to fit it into what I already knew because I thought I knew everything back then. And I wish I hadn't had that chip on my shoulder because I would have got exposed. I would have gone and done Shirley's fellowship, for instance, a lot earlier. But I did have that chip on my shoulder. So I saw Shirley Sarman, for instance, a few times at conferences, and she was talking about the hip. And I'm sort of thinking, yeah, that's exactly what I do. It's just, they get stiff in the back of the hip and they get a bit of an anterior glide syndrome, when in fact she's not talking that language. She's talking about something completely different, but I didn't really sort of hear it because I had this chip on my shoulder. Subsequently, over the years, I did some Maitland versus McKenzie versus Sarman sort of throwdowns where we would have a practitioner from each of those sort of approaches do a seminar and we'd treat a patient and then we'd sort of discuss things. So the first one I did like that. I was the Maitland representative. There was a McKenzie guy there. And then the Sarman representative was Shirley Sarman, which was sort of pretty intimidating. And I remember my patient was like the worst patient you would ever want as a Maitland therapist because it was a guy who had back pain that came on at 5 kilometres after he was running. And when I'm assessing him in the clinic, I couldn't reproduce his pain in any way or form. Like, I'm doing combined movements, quadrants, overpressures, repeated movements, everything I could do. No pain, nothing. So, and in the Maitland system especially, you really like to find that comparable sign. So in the end, I decide I'm just going to do a unilateral PA on where it hurts when it does hurt, but it wasn't hurting at the time. And I'm telling the crowd, well, my theory is he fell off a stool, which this was his mechanism of injury, and he's hurt his back, and now it's a bit stiff, and when he gets to the 5K point, it's starting to get aggravated, so I'm going to loosen it up for him. And I flippantly said, because Shirley's sitting there on a computer, working away on a computer because she's never actually paying attention, even though she hears everything. I said, but Shirley probably thinks something else. And she goes, he moves too much. And I'm like, what are you talking about? And I didn't understand what she was talking about at the time. So that night I said to her, look, he's not really one of my sort of patients. I don't really know what to do with the guy. Why don't you look at him the next day? And she looked at him and she found all these faults, and, he had weak glute medius and tight TFL. And basically what she came up with was that when he ran, he rotated and extended too much in his right lumbar spine, which overloaded the joint down there, and he got pain. And that was a completely different way of thinking to what I was normally, as a manual therapist, sort of thinking. So I thought, I better go and learn this stuff because I've got a gaping hole in my treatment approaches. So that's why I went back and did this fellowship. So as I've gone through my career, I'm always looking for the perfect treatment model, but really it doesn't exist because I don't know any therapist who gets every single person better. But I will be exposed to things and think, oh man, that's really clever, because I've never actually had an original thought in my life, but I'm smart enough to see other people who are very clever and have good models. So Shirley's model changed a lot of the way I treat and allowed me to treat some patients that I wasn't getting better before. And then Peter O'Sullivan and all that pain neuroscience stuff, I think, was probably the other big thing I picked up quite a few years ago regarding what goes on in people's brains and all that sort of stuff. So I've been able to integrate all these models, and the way I do it is if you do a really good subjective, not pursuant to your question of how I integrate it, if you do a really good subjective, you start to hear that they sound more like they're amenable to manual therapy or a McKenzie approach, or maybe they've got a lot of things going around in their head that are maladaptive that you need to address. So after the subjective, it points me which way I want to go as far as my physical assessment and treatment approach. Generally, you're doing a bit of everything, aren't you? When you're treating a patient, you're sort of getting into their head. Even if you're doing manual therapy on them as your primary treatment approach, you might be saying, well, I'm not damaging you, or when you're getting them to do a McKenzie exercise and they get a bit of pain, you're getting into their head to sort of explain to them that you're not damaging anything. So you're sort of incorporating all that stuff together. But what we try to do is say, what's the main problem? So you'll have patients that literally the main problem is they have catastrophic thoughts about their back because doctors or other therapists have put ideas in their head. And yes, they might have a movement fault, and yes, a little bit of manual therapy might help them. But if that's the main problem, you should start with addressing that first, because you're not going to be able to get to the other bits without it. Versus someone might come in and say, I was in a motor vehicle accident 3 weeks ago and I've got a really stiff neck and it's right there. And you ask them questions about what's going on in their mind and they don't seem to be particularly having any bad thoughts. I think, okay, that's going to be beautiful. I'm just going to sit there and do a manual therapy technique on them and get them better. So my thing is your subjective is really the key to guide you in where you want to go in your approach.
I like what you said, like recognizing when you're, lacking something that you think you have all the answers, and then you start looking to things in a different way or listening to other thoughts and approaches. And I think that is really important, just, being able to recognize that and being open, because I feel like today there is a lot of separation between approaches and, I'm the best and I'm the best. So
Yes.
I think that it's plays like a huge part on, being a more complete therapist and being able to help more people with different approaches, recognizing which one fits the patient better. And when you're talking about the subjective, I wanted to ask you, when you are assessing, do you follow like a specific rationale from a specific approach, or you kind of like develop your way of assessing, integrating a few pieces of different like methodologies?
So, I was trained with a Maitland sort of subjective, which actually is a pretty thorough subjective. But you've got to have a system, don't you? If you don't have a system, no matter what the system is, you're going to get lost. So the problem with new grads is they haven't really got their system down pat. And we would see this in the fellowship programs where they would come in and their subjective is over in 5 minutes because they haven't really thought about the subjective properly, or they're nervous and they don't get their system down pat. Now, that doesn't mean I sit there and ask them, a series of questions in order. I always start with, so what's going on? And then I sit back and I just let them go. And I think there's some research out there that says most clinicians interrupt the patient within 30 seconds. And you miss a lot of information, spontaneous information, if you do that. And I've even had some people, even when I was doing my doctorate, I went to a course and the guy was saying, no, you've got to control the interview. You've got to tell the patient to answer the questions in the order you give them. And I think that's the exact opposite of what you want to do. You just want to let them go. Now, if you get a waffler who's spent 10 minutes telling you nothing, you need to reel them in a little bit and sort of tighten up that sort of thing. But generally, I will let them go until they run out of breath. And then I may start specifically with my questions. And we always had a debate, actually, at the fellowship program I was at. Should you start with the body chart or should you start with history? And I think the answer is let the patient decide for you. Often they go between the two. My neck hurts and I was involved in a motor vehicle accident 3 weeks ago. I just let them go. And then I'll fill in all the blanks, because you do have to get into the body chart and find out, is the pain constant or intermittent, deep or superficial? Is it related to another pain, et cetera, et cetera? So generally I just let them go, but then I fill in all the gaps. And over the years, I will, like for instance, in addition to now, I will ask them a lot about what they do during the day that isn't just an aggravating activity. So in the Maitland assessment, the aggravating activities are huge because that's where we determine irritability, which helps us decide how aggressive to be in assessment and treatment. So we really want to know, when does it hurt? It hurts when I sit. Okay, so how long do you have to sit for? What does it do? Does it ramp up to the point that you have to sort of get up and walk around, or does it just plateau out? And then how long does it take to settle down when you do? So that's how we establish irritability. But Shirley Sarman's crew are also interested in, well, what else do you do during the day? Because those movements that you do repetitively, they can set up these movement faults that you see in your exam. Classic case being nowadays people who sit for 8 hours at a desk. They end up with that sort of anteriorly tilted scapula and they're depressed scapula and they have this movement fault, and you want to know why, or this postural fault, so that you can then, in your hypotheses that are whizzing around in your head, you think, okay, I've got to give them an exercise to correct that, and then maybe I need to look at ergonomics of the situation so that I'm taking them out of that particular thing that they're doing lots of. So I'll add that into my subjective now. And the other thing I've added in that I didn't really have early on was the psychosocial stuff. that I think Peter O'Sullivan's crew do better than anyone else. And I will literally do an assessment. It's almost like you're doing a full assessment where I'll ask them, okay, so what do you think is going on? And then you'll hear all sorts of crazy things. And then they'll say, well, I think I've got a hernia. My disc is bulging out because the MRI shows this. And I'll be like, well, how did you feel when the MRI, you were explained to the MRI? And this is how you're going to work out their maladaptive thought processes, if they have any. So I go into it a lot more than I used to. So they're sort of the tweaks that I added to the Maitland thing. I can't recall, the McKenzie assessment's good, but it's sort of, we were asking a lot of similar questions in the Maitland assessment with regarding aggravating activities and that. With the physical assessment, what I got out of the McKenzie stuff, as I mentioned, was the repetitive movements. They're the kings of repetitive movement, aren't they? They, as a Maitland guy, I used to say, okay, bend backwards, and you might go, oh, there's my pain. I would, as a Maitland guy, I'd go, all right, good, stop. We found your comparable sign. Let's move on. Now, having done McKenzie, I'm like, well, do that again, you know, and you pick up the magic things after 10, 15 repetitions. And I'm not the best McKenzie therapist in the world, because when I do these courses where I'm the Maitland guy and the McKenzie guys there, they do way more repetition than even I do. And sometimes they find things that I would never find. And sometimes they blow them up as well. But that's why I don't do as many, because I sometimes get worried, I might aggravate you too much. But, I mean, you've done the McKenzie stuff. You'd have to admit he revolutionised the profession by this repetitive movement stuff and the concept of, you know, peripheralisation and centralisation.
Yes, absolutely. And when you were talking about like the aggravating things and irritability, I was just thinking in my head, like, what makes you worse? What makes produce the pain? Like our MDT language, which I think it ends up being very similar to what you were talking about on the Maitland. So
yeah, and it's funny. I heard Brian Mulligan at one of his conferences years ago. He said, yeah, I don't have a subjective and stuff, because I basically just say, go and buy Jeff Maitland's text. Because as far as he was concerned, he couldn't improve on it. So, and the way I use the Mulligan techniques is you try the technique, and if it works, fantastic. And if it doesn't, that's it. That's basically,
move on.
Yeah, and it's brilliant stuff. There's no doubt that it's brilliant stuff. But it's, again, you just integrate it into your sort of physical assessment.
Yes, absolutely. And then like on the psychosocial, do you follow like a specific thing, or you just go asking those questions, or do you have like a questionnaire or anything in particular that you use?
So I have written out, like for me, to get good at it, what I suggest people do is a couple of things. Or first of all, go and read a lot of Peter O'Sullivan's stuff and the cognitive functional therapy stuff. And they have a brilliant little PDF book that you can get online called the transitional. I can't remember what it is. You'd have to look up Darren Beals, Helen Slater. They produce this nice little book that really goes into that stuff quite well. A lot of the new books, like Greaves' Modern Manual Therapy, has a lot on the psychosocial, and then Darren Revet's and Mark Jones' clinical reasoning book goes a lot into it. But what I do is I think, what would you think if you were a patient? What sort of thoughts would you have in your head that you might want to ask them? And then also you can actually go and get the various questionnaires, like, you know, the fear avoidance questionnaires and the catastrophization questionnaires. Read all the questions so that you just get an idea of what you want to ask. But I'm not a big questionnaire guy, because I think you lose that body language and what's going on, basically. And that part of the assessment is that your opportunity to connect with your patient on a whole different level. And that's when some of your patients will start crying. You know, I'll say to them, so how's this making you feel? I mean, God, you must be really depressed having all this pain, you know, especially a lot of these chronic pain patients. And they'll literally break down, you know, because they're going down a dark path of pain and inactivity and bad beliefs in their head and blah, blah, blah. And we've got to try and steer them back onto the good path, but you got to know what they're thinking first, don't you? So I sort of just develop it, but I sort of hate questionnaires actually because they're so impersonal. The advantage is sometimes you pick things up in questionnaires that people are too embarrassed to say to your face. My biggest problem with questionnaires is my patients spend half their life in the waiting room filling them out. And, by the time they get to me, I'm running half an hour late sort of thing. So I would always rather actually talk to them about it, and it's a good point to get your therapeutic alliance going. What do you do?
I ask questions, and I'm trying to get I was asking because actually I'm trying to put some little questionnaire together. I've been researching different ones, something that's kind of short, but you can still assess. But I agree with you that definitely talking is the best way because you can see their expressions, their reactions, and
and it allows you to move into discussing, because especially with the chronic pain patients, I think it's important because you're trying to get into their head as to why they won't do some of the things they should probably do to get better and things like that. The other big thing I sort of gleaned out of Pete's stuff is the motivational interviewing, which I'm not an expert at, but I wish that should have been the first thing they taught us at PT school, because I spend all day trying to get people to do things that they never do. So how do you, and flippantly, we often, as a bunch of therapists, we all sit there and criticise our patients because we give them the answer, but they never actually go and join the YMCA and do the program. But the failing's probably in us because there are strategies where you shift their motivation. I'm just not an expert at it. I don't know if you've had anyone on your podcast to talk about that. But if you have, tell me which episode so I can go and listen to it, because it is really hard. And there's there's a lot of references out there, and there's books on motivational interviewing. I just haven't got into it as much as I probably should have.
Yeah, we had one on behavior change that was very interesting.
Yep.
Yeah.
We're very good as therapists at telling people what to do. And, you can tell a smoker not to smoke and he still goes and smokes. He knows he shouldn't smoke. Yeah. You have to shift his brain in some capacity, and that's an art form that I'm still working on.
Yeah. And I wanted to ask you about the movement fall that you mentioned a few times. So what is the theory behind it? I'm not familiar with that. It's just like a muscle, like you're following the muscle patterns, how is that?
I'll try and explain Shirley's stuff. Don't let her listen to this though, because I did a year of their program. I did a fellowship in it, and compared to the people who are really good at it, I'm like an absolute amateur. And Shirley herself is like a savant. She could literally watch you walk in the room and tell you what's wrong with you because her eye is that well trained. But she'll always go through her assessment. And it's interesting. She says she has a standardized assessment and she goes through it and she doesn't miss one test because she reckons she'll think she has it in the first 5 minutes and then something pops up, 10 minutes in that completely changes the way she thinks. But their system is based on you develop sort of movement or postural faults based on what you do. And you see this in athletes a lot, when you look at rotational sports, quite often they rotate a lot to the side. They do a lot of the rotation too, like golf or throwers, and then they lose range of motion the other direction. So you can get these faults. And the body's pretty resilient, so it can handle not being perfectly symmetrical, etc. But sometimes these faults just result in overload of tissue. So Shirley's very big on, she thinks that we should own the movement system as physiotherapists. That's our system, just like neurologists own the nervous system. We should own the movement system. And she feels that we should actually label we should have a standardized language, because physiotherapy's got all sort, McKenzie speaks a different language, Maitland speaks a different language, no one's on agreement. I've often said to her, good luck, that's never going to happen, but I like what you're saying. But the way they label a problem is they will label, like that guy I was talking about, the runner, he would be labeled as an extension rotation problem because his lumbar spine extends and rotates too much for whatever reason. So, and those reasons can be multiple or different with different patients. So you might have a patient who comes in and they have weak glute medius, and when they run, that's going to set up that fault. Whereas the next guy might come in and his glute medius is fine, but he's got a stiff hip joint or something. So the real trick with their system is working out what's causing that fault. That's where I struggle because it's just quite complex. But I did learn some basic things. So often you see with, like I was talking about, office workers, they're on a computer all day long like this. You can just see my scapula is going to be tilting forward. It's usually depressed. It's usually got insufficient upward rotation. And so when they look at necks, they always look at the scapula, because the scapula is attached to the neck, isn't it, through levator scapula and the traps. And if your scapula's hanging in these abnormal positions all day long, their theory is that either the shoulder girdle's dragging on the neck to set up neck pain, or the muscles are working, trying to do their job, but because they're longer and weaker, they get overworked. So how often do you see people with upper trapezius pain? And they're like, oh, I've got rocks in there, and can you get in there and loosen it up for me? And we give them all these stretches and stuff, where the problem is really that they're too much depressed, and we should really be giving them lots of elevation activities to sort of offload that muscle and sort of strengthen it up and get it more resilient, and then it won't be dragging on the neck. So one of the assessments I do now when I look at a cervical spine patient is if they have limited rotation. So I'm sort of doing my Maitland, just basic sit back and look at their range of motion. If they can't rotate well, I elevate their shoulder girdle by sticking my hands in their armpits, and then I elevate it. And quite often they'll go from 45 degrees rotation to 100 degrees 90 degrees rotation. You try it. Do you do that with your patients?
No, I never tried that.
Okay,
I'm
so
curious
try
to
that.
See now.
This is a great Shirley trick. I picked up a few tricks. And when they do that, that tells me that scapula hanging on the neck has something to do with it. I mean, if I can get all their pain gone and their full range of motion by just elevating the shoulder girdle, I need to do something with the shoulder girdle. And then you give them a bunch of exercises. And that's where Shirley's renowned for her wall slides. You've seen the wall slide exercise. They base the wall slide on the scapular diagnosis. So if it's anteriorly tilted, when you do your wall slide and you lift back like that, you're posteriorly tilting, aren't you? If it's depressed, when you do your shrug, you're elevating. So that if it was too abducted, you wouldn't want to sort of do this, start here, because then you're abducting it even more. You start wide. But if they're too adducted, which some people actually are too adducted in their scapula, you would start the wall slide here to give them more abduction. So not to get too complex, but they're very specific in their movement diagnosis. And so they look at the scapula for shoulder patients, they look at the scapula for neck patients, and their theory is that movement fault just causes overload of various structures. So as a manual therapist, we're really good at localizing the tissue that's causing the problem. So I might be able to say to you, it's C5-6 because I've pushed on C5-6 and that's reproduced their neck pain or their arm pain. But I now ask myself, why is C5-6 overloaded? Why is it not happy? If I heard that they were in a motor vehicle accident 3 weeks ago, I'm probably going to think, they probably had this posture forever, and maybe I don't need to correct their posture as much. It's just a simple manual therapy or McKenzie type approach. But if they said to me, well, it's just been coming on for the last 6 months, I'm not sure why, I changed jobs, then I would think I really need to work on posture stuff. So that goes back to your subjective guides where you go in your treatment approach.
Very interesting. We have to bring her here to the podcast next.
Yeah, I'll try to hit her up. She's a busy lady, but she'd be a good one for you. Yeah.
Yes, very interesting. And so, like going through the subjective, would you have a little tips just like to tell us what would be the characteristics that would make you think about, okay, Maitland's going to be the best for this patient, or McKenzie would be the best for this patient? The psychosocial we already kind of mentioned, like you have to address them first, and then or the movement fault. So like, how do you, like, what makes you like think about that patient is going to respond to this one? We know we have a lot of experience, right? You have a lot of experience, but do you have any tips for us?
I think that if someone comes in and there's an injury, as I said before, often I'm doing both. I'm sort of like, if someone comes in and they say, look, I've got neck pain, I've had it for 5 weeks and I don't know what it is. And I'm thinking, okay, it may be ergonomics at work and I need to give you those wall slide exercises. I'm still going to treat your neck, because I'll give you an example. I've talked to some of the faculty at Washington University, and they weren't doing a lot of manual therapy. They were just really following this MSI. It's called MSI, Movement System Impairment Approach. And I remember one girl saying to me, I had this guy, I had thoracic pain, and I was doing all the stuff we're meant to do in our system, and I just couldn't get him better. And then I manipulated T4 and he's better, sort of thing. But then they would also add in the movement retraining, because that pain may come back later due to whatever he was doing, his postural fault. So in the subjective, if they sort of describe no specific mechanism of injury, or if you sort of somehow you're tying it into they've increased the load of something they're doing. So I just got a new job, I'm sitting longer, or I've increased my mileage in running and now I'm falling apart, I would definitely have a look at their movement in some capacity. If it's a basic, I hurt myself 3 weeks ago and I've got a pain here or in my shoulder, it may be just a matter of moving it. I sort of lump Maitland and McKenzie together as just repetitive movements. When it comes to the treatment, I look at them as repetitive movements and when you do a repetitive movement to a joint or a tissue, lots of things happen, don't they? So you may be getting a mechanical effect, you're getting a neurophysiological effect. At the biologic level, you're getting all sorts of cellular changes. And then I start thinking about time frames. So if it was someone who I thought had tweaked their knee, a meniscus or something like that, I might not necessarily think I'm going to be able to get a miracle on the first day. But my knowledge of the fact that if you move something repetitively over a long period of time, it can remodel tissue, then I'm factoring that into my treatment sort of approach. So my model of movement therapy sort of looks at short-term effects, long-term effects, neurophysiological effects, things like that. And I know in our profession currently, everybody seems to think everything's a neurophysiological effect. I've heard podcasts where people are like, manual therapy works because it works on the nervous system. And yes, it does work on the nervous system, but I also think there are times when there's a huge mechanical effect. I mean, explain how a mulligan technique can change the way you move instantaneously and it sticks when you've had pain for months. It's not a neurophysiological effect, is it? There's something else going on. So I no longer care as much why I get people better. I just want to get them better. But I know a lot of people, they want the answer, like, why did they get better? Did you realign a joint? Did you make a joint less stiff? What did you do? I'm not as concerned anymore because I don't think we have the answers. And I think with different patients, different things happen. But manual therapy's taken a bit of a bashing in the last few years. I don't know if you've noticed. Have you noticed that?
Yeah. Yes.
Due to certain social media people who love the sound of their own voice, they say things like manual therapy sucks and things like this. And I just don't understand it, because it's just a tool in your toolbox. And sometimes it's the only tool that works. And then at other times, I agree that you could just give them exercises and get to the same place. So to sort of say, oh, that tool is useless, I don't understand the logic of it. So, but what I have noticed is that manual therapy, usually you'll get a pretty quick result with it. And if you're not getting a quick result, then maybe I fall back on sort of other strategies of exercise and things like that.
And when you're saying like the manual therapy that usually you see like quick results, so when do you decide to try like repetitive movements? Like, do you go for, manual therapy first, and then if needed, you do repetitive? How do you choose between those approaches?
So I always say this on courses. I have someone doing we'll call it a McKenzie push-up, because he is renowned for that. And I will say, just as you said in your podcast, I listened to it with Stephen May, McKenzie is not just repeated lumbar extension. It is repeated movements, look at what's happening, and then from that you decide which way you want to move them. Quite often it's repetitive flexion or side glides or whatever. But everybody thinks that McKenzie's repetitive extension and Maitland's just pushing on a joint, which is absolute rubbish as well. But I always say, so I have someone doing a repetitive extension, and I say, what is that? How would you describe that in a Maitland-esque term? And for us, that's just repetitive passive extension. So as a manual therapist, if you decided you wanted to do an extension mobilization on the lumbar spine, you could grab their legs and do this thing where you'd be sweating bullets and exhausted within a minute, or you can just get them to do a repeated push-up exercise a la the McKenzie type style, and you're achieving the exact same thing. So I will run them through. In the lumbar spine, I run them through the repetitive movements, and if repetitive extension seems to decrease their pain and centralise them, I go for that first, because they can do that at home. But sometimes I'll also mobilise them pretty quickly, whereas the McKenzie guys, they're sort of like, we don't touch them until we've failed with, patient doing their own stuff. I have no problem getting my hands on them pretty quickly, because I know it works so well. So a classic Maitland guy might do either a side-lying extension passive movement. I think that's just the same as doing a push-up. Why you decide to do that might be slightly different. So, for instance, a Maitland guy might see someone extend and they say, oh, that hurts in my back. And the Maitland guy then goes, okay, well, this person's had this problem for 3 months. So they're not in an acute phase. And based on their irritability, we would then decide how aggressive we want to be at doing possibly an extension maneuver. Whereas McKenzie people look at it more from is it centralising and things like that. But I don't like sort of getting in the silos. I just look at it as movement. So if I extend you repetitively and you say that feels better, or you're getting centralisation, then that's a no-brainer, because as Stephen May said, centralisation is such a powerful tool. Why would you not want to use it? If it's just localised central pain, how do you work out if it's centralising? You can always just sort of find the comparable sign. They might have a problem flexing or whatever. Do the repetitive extension, then reassess. And if they get better, that would be a good enough guide that I might trial that. And I always remember from my McKenzie classes that they often say, if you're not clear, just send them home with it for 24, 48 hours and see what happens, because things often change a lot over a period of time, don't they? You don't always get that within the clinic change immediately.
Mm-hmm. Yeah, absolutely. And then sometimes even to expose the problem is the approach.
Yeah. The worst words I hear from a patient are, I'm the same. If they come back worse, you at least know you can change something. And I always prefer I'm better. But when I hear I'm the same, I just about go insane myself.
Yes. And so do you recommend for like the clinicians that are listening to us, if they want to, improve their skills, to like try one system at a time, like, and then try to be good at one system and then slowly adding more, methodologies, different courses, so they don't get too confused or.
So, like I said, I was lucky. I was exposed to a system. So going back to what Maitland is, everybody thinks it's joint mobilisation, passive joint mobilisation, which back in the day, 60 years ago, when Jeff Maitland travelled the world, and the at that point in time, you sort of had two sort of parallel universes. You had the movement people like Shirley Salmon and Yanda and all these people, and then you had the manual therapy people, Colton Bourne and all this other crew around the world, Paris, etc. So back then, manual therapy was the hot way to treat musculoskeletal problems. And Jeff Maitland got associated with that sort of oscillatory passive movements, not manipulations, but oscillatory passive movements. But what he's really about is the clinical reasoning. That's what Maitland is. Maitland is clinical reasoning. Now, that's not to say that or any other approach isn't clinical reasoning. Obviously, they are. But if you look at most approaches, they sort of have a theoretical construct of how the body works, and we do this to it to get the body better. And what I've noticed with gurus is gurus get stuck in a silo, and that's why they're gurus. They're so good at what they are specialists at. They're unbelievable. But often if something comes along that doesn't fit their box, they sometimes have no idea what to do, basically. And I didn't really want to be that therapist. I wanted to be able to treat more stuff. So in the Maitland system, or the Australian system, hallmark of our clinical reasoning process is, as I said, you've got to have metacognition, or you've got to continually be thinking about thinking and why you... I've seen a video with Jeff Maitland where he says the essence of my approach is the way one thinks. And we like non-dogmatic, lateral, the world is grey thinking. We do not like vertical, algorithmic, everything's black and white thinking. Because if you're a vertical thinker and you go and do a McKenzie course, the way you're going to incorporate that into your world belief is different from someone like me who's a lateral thinker and will put it together in a different way. So every clinician is unique in the way that they interpret new knowledge, type thing. But what we say is, Jeff Maitland, and I think you just had Chris Showwater, the Maitland guy in the US, on your program, and he probably talked about that dual brick wall thinking. Do you remember hearing about that? Where
I don't think so.
So Maitland talked about a permeable brick wall, and on one side you've got what we know, what we think we know, anatomy, physiology, biomechanics, all that sort of stuff. And then on the other side you've got what's happening in the clinic. The patient bends backwards and they say, that feels better. And on this side, you've got an X-ray finding that says they've got a spondylolisthesis, and your brain starts going, oh, my God, how does that fit together? Because when I was at university, you're not meant to feel better when you've got a spondylolisthesis when you bend backwards. So how do you get the two to match? You've got to have a certain comfort zone with grey. So if you don't know, for instance, that spondylolisthesis can exist in an asymptomatic population, you're going to have a problem putting that together. If you do know that, you're going to put it together. But the point is, you never know everything, do you? So you've got to be comfortable in the grey zone. And then what we do is we utilise a concept that comes out of Australia by Darren Earnshaw and Mark Jones. They're called hypothesis categories. And the hypothesis categories, I forget how many there are actually. I just do it automatically in my head. I think there's 8 of them, but they're things like patients' perspectives, management, what structure could be causing the problem, what are the pain mechanisms. it asks you questions that are meant to make your brain go in all different directions as you're collating data. So not only do you need a system of getting the data in, because if you don't get all the, we use the analogy of a jigsaw puzzle. Your patient's a jigsaw puzzle, and he's just a jumble of jigsaw pieces, and you need to pull the pieces out and put them together, and then you get a picture of what's wrong with them. The skill of pulling those pieces out, like your subjective and your physical assessment, that's a skill in itself, isn't it? Because if you only have 5 pieces, there's no way you're going to get the picture of what the jigsaw puzzle picture. The more data and the more information you get, you can fit it together better. But the way you fit together that jigsaw puzzle will be different from the way I fit it together, because based on my belief system, those pieces are put together in a different way. But what we do is we utilize these hypothesis categories, and we derive clinical reasoning sheets. Did you ever use clinical reasoning sheets when you were doing your at school? So these clinical reasoning sheets are based off these hypothesis categories, and what they do is they make a student think in lots of different directions. So, for example, if someone came in and they've got thigh pain that happens when they're riding their bicycle for a period of time, one of the questions is, what structures could be causing this problem? Now, most of us would say could be the hip joint, therefore it's the articular surface or the labrum, could be the lumbar spine, could be a quadricep muscle. That would be sort of the main things that most people think of, but could be a nerve getting irritated somewhere. But you wouldn't normally think of a blood vessel, would you? But however, it could be a blood vessel, couldn't it? Because there's some nice case studies on cyclists who impinge that artery. By having a tool that makes you think beyond your usual way of thinking, you get more hypotheses. So these clinical reasoning sheets, which are based on your hypotheses, are a tool that we utilize to stimulate clinical reasoning. And honestly, to become an expert, I don't know how else you would be able to do it without having some form of tool to stimulate this clinical reasoning. But the way you use a clinical reasoning sheet versus the way I would use it will be different based on the way you think. So if you think very vertically, you're going to think of things slightly differently. And also, if your belief system is different from mine, you will come up with different hypotheses to me. So it's quite a complex system, but becoming an expert was never meant to be easy, sort of thing.
No.
So,
and yeah, you have to keep your mind open to all the possible diagnoses, and for sure they're going to be different based on your beliefs and experiences.
Correct. But
we
even
go back to the beginning.
Yeah, but even if you've, like a guy like me, often I will get tunnel vision with a patient. I'm so set in my ways that if I go back and do a clinical reasoning sheet or start thinking that way, it'll make me think of different things, basically. So I would highly recommend to novice therapists, aside from working on your subjective and getting really good at that, find these clinical reasoning sheets. You can email me or something and I can send you the ones that I utilize. That you can find them. The best book for this probably is Clinical Reasoning for Musculoskeletal Therapists by Darren Earnshaw and Mark Jones. And you want the second edition. The first edition is good, but the second edition is much more updated. And it has these clinical reasoning sheets in them, and it explains how to use them and things like that. That was probably the best thing I got out of my fellowship, and it's probably the best thing, in my opinion, that the Maitland system offers, because it's a way of stimulating advanced clinical reasoning.
Yes, and it's funny because I was just thinking about some patients that I missed because you get so stuck sometimes, and then I was like, but why they don't get better? And you stop to think about, I was like, why did I test that? Why didn't that come to my mind before? Because sometimes you just stay, like you said, with this tunnel vision. Yeah. And so I think at least that makes keep your mind open to all the possibilities. And sometimes you just don't
you
get stubborn on your
you
theories.
need something to get you out of your box every now and then, because you do just get set in these patterns. That's what makes an expert. You've got a lot of pattern recognition, but the trap of pattern recognition is that you just get stuck in it. I've had new grads come in and mention something, and I'm like, oh, yeah, good point. I forgot about that, or I didn't think of that. Mm-hmm. And they were the ones that sort of solved the problem. So
sometimes you wanna put them in that box that you are familiar with, and sometimes they don't fit there. Yes, and you keep trying to put them there because that's what you're familiar with. And
hence why I tried to go out and get more tools in my toolbox, because if all I was doing was treating them with manual therapy, I was having a lot of frustration, because a lot of people don't get better with just that. And the McKenzie approach, as good as it is, if you fall outside the box, you got to go somewhere else, which I actually respect the McKenzie guys, because that's what they'll say. I've been in sort of talks where there's an expert McKenzie guy, and someone will ask him, what do you do if they don't fit your box? He says, I send them to someone else. If they fit my box, if I do my assessment and I think I can help them, I help them. If they don't fit that, I send them to someone else who's got a different approach. And I sort of thought that was the best answer I'd ever heard, sort of thing.
Well, at least you don't have to, be the best at all the different things. At least you're
But I actually would like to be able to treat a few different. I tend to find, McKenzie works great if in the lumbar spine. In the neck, I haven't had as much success. I tend to go back to a bit of manual therapy and stuff. But with chronic pain patients, they're a whole different kettle of fish. And I don't know if you see a lot of chronic pain patients, but they can be a complete nightmare. And I will always try to get the miracle with a manual therapy approach first. You've got to make sure you try the quick fixes first, because you will get surprised. Someone will come in who's had pain for 15 years and you hear their story, and in my mind I'm thinking, oh, classic chronic pain patient, I don't even need to touch you. And then you go and mobilise their back and boom, 2 sessions, they're like, oh, I feel fantastic. If you didn't try it, you would never know, sort of thing. And same thing, you might try the repetitive movements or whatever, but if all that fails, then you've at least now with some of the chronic pain approaches, especially like the stuff Peter O'Sullivan's crew are coming out with, I think you still got stuff that you can do to help those people as well.
Yes. And Darren, before we transition to the final questions, anything else that you want to add in regards to our discussion, everything that we said, anything that you want to...
What is my other pet peeves? I think Chris Show would have talked about this too. Just how I'm finding it interesting that every 10 years or so, we recycle stuff and claim it's new. So the last conference I was at, they were talking about precision medicine, and now we've got pain phenotypes, which I'm sort of thinking, well, precision medicine is actually trying to assess your patient and take all these myriad factors that are included in those hypothesis categories to me, and tailoring a very precision for that one person treatment approach. So you're trying to subcategorize them into the whatever category. So at the last FAAOMPT conference I was at, they're talking about precision medicine. We're the only people doing it in the States, and it's new. And I'm thinking, this has been around forever. I was doing this 30 years ago, basically, just under a different name, basically. So you see a lot. And the other thing I'd like to add, which goes back to what you asked me about, what should clinicians do? Should they go and learn one specific approach? I think you sort of almost have to do that, because if you start doing too much at once, you get too confused. But I would say go as close to the font of the approach as you can get. So if you're going to learn McKenzie, don't learn it off a guy like me who did a McKenzie course. Learn it off the McKenzie Institute that has expert McKenzie instructors. If you want to learn Maitland stuff, go to the Maitland guys. If you want to learn Pete O'Sullivan stuff, try to get in with his group. Same with Shirley's group. They have a fantastic course at Washington University. But what I notice a lot nowadays is people go around and do a bunch of continuing ed courses. Then they mishmash it together. They call it their own method. and they sell it as such. And then when I'm sitting there watching it, I'm going, but that's just McKenzie stuff, but you're doing it in a watered down version. So my advice would be go to the originators of this, get the sort of 100% version of it, then you can water it down yourself if you so wish. But that's my opinion on that sort of if you're a new grad. And if I was a new grad, I would definitely go to the McKenzie stuff. I would pick a manual therapy approach. I'm Maitland biased, obviously, but there's lots of other good ones out there. I would definitely look into Peter O'Sullivan and Peter O'Sullivan stuff and pain neuroscience. And I would be looking at Adrian Lau or Butler's group in Australia. And then I would also look at a movement approach. And I did the MSI stuff, but what's the other group? The FMS group have a nice little way of looking at movement and things like that. Gray Cook's group and things like that. So that's basically what my system is. I have a bit of manual therapy, McKenzie, Mulligan. I have a nice psychosocial approach through Peter O'Sullivan and the pain neuroscience. I've got a movement approach through the Salmon people and whatever I left out.
Very interesting. A good overview of the basic pillars,
Correct,
the basic,
yes.
And give it a time to practice a little bit of each, so you don't just think that I learned McKenzie's extension, so I do McKenzie. I'm exporting McKenzie, and then do like a central PA. Okay, I'm a Maitland expert,
Yeah, exactly. That's where the clinical reasoning and the clinical reasoning sheets and hypothesis generation comes into it. But there is a tendency, if you go and do a McKenzie course, I was the same. I try it on every patient that walks in the door for the first few weeks. And then you soon realise it only works on certain people, and you develop that pattern, and now you will integrate that in a way that, like, I've been doing this for 30 years. I'm pretty good at integrating it and picking the right approach. But the only way you're going to get there is by actually trying it out and seeing what it works on, etc.
Keep your mind open to try different things.
Correct.
If they don't work, then you have another option.
Yeah. If you got a chip on your shoulder, knock it off. The sooner you knock the chip off your shoulder, the sooner you're going to grow and progress as a therapist, because having a bit of, we're all ego driven and we all want to be the best, but after a while you think you're the best. That's the biggest mistake you can ever make. You're never going to know everything, and unless you're continually changing your pattern of treating, something's wrong. Because if you came and saw me 5 years ago, I'm treating differently today as I was 5 years ago. So I meet therapists who was doing exactly what they were doing when they graduated 20 years ago. And I'm sort of thinking that's probably not good, but that's just my opinion.
Yes. And I know you mentioned a lot of books and resources through our conversation. Anything else that you would recommend to the listeners to go check as a resource?
Yeah, I would recommend, so if you want to get a good subjective down pat, Maitland's book has a great thing on how to do a great subjective. I would get Darren Rivette and Mark Jones' book, as I mentioned, that Clinical Reasoning for Manual Musculoskeletal Therapists. I would get that translational framework. They're the first two words of the book. It's by Darren Beals, Paul Mitchell, and Pete O'Sullivan and Helen Slater. It's a PDF. You can get it online. It's like $20 Australian, which is probably worth $2 US nowadays. But they're the ones I would recommend, because if you sort of got into those, your clinical reasoning will improve out of sight, and your psychosocial stuff with the Peter O'Sullivan book will improve out of sight.
Very good. Darren, if people want to learn more about you or contact you, is there a way that they can find you?
Yeah, you can. I created a website that no one ever goes to, so this could be good for me. Thinking I would get lots of telehealth patients, but of course I didn't mark it. But if you put in like the physio Earnshaw or Earnshaw physiotherapy, if you Google it, you'll find I think it's under ePhysio online, but you'll find that website with me, and then you can just through the website contact me. That'll be the easiest way.
Awesome. Darren, thank you so much for taking the time and share your knowledge with us and your rationale, your experience through the years, the things that you develop and the way that you treat and assess. So I appreciate it. I'm sure the listeners that are listening also going to learn a lot. So thank you.
Well, I hope so. But it's been fun. Thank you.